Hello, this is Rahul Saka. I am a respiratory physician and intensive care consultant based in the UK. COVID 19 is currently running havoc across continents. We are learning about the disease every day, as sometimes it can behave slightly differently from other viral diseases. These issues are being discussed widely amongst clinicians in journal articles and webinars. It is vitally important that we also hear from our virology colleagues about diagnostic challenges, scaling up testing, and a lot of other different issues around sampling. We are lucky to have Dr. Sudhanva, the UK clinical lead for the UK Biocentre and virologist at King's College London. We also have Dr. Sanjay Bhattacharya, a well-known name in the field based in Kolkata, India. They will discuss about opportunities, challenges, and unique issues with diagnosing this virus in a patient suspected of COVID-19. They will bring the perspectives from both the countries. I think this will be immensely informative, and I welcome both of them today.
How's your diagnostics there? What are you doing for the diagnostics for coronavirus SARS-CoV-2?
Well, I must tell you that we are going to start the diagnostics, but we are a bit late in that process because although we have received the government permission, which is required from the Indian Council of Medical Research, hopefully by early next week, we are going to start the first runs. So the plan is to run it, have more than one system in place. Obviously, all of them are real-time PCR-based systems.
Yes.
The government, that is the National Institute of Virology labs, have done evaluation for quite a few real-time PCR kits, and we have selected a couple of them from there, which have shown good concordance with both positive and negative controls. And but we are also working on the possibility of a syndromic panel, which includes COVID, which is FDA approved and ICIVD marked, so that there would be patients where an extended panel would be useful. And so we are currently working on at least 2 real-time PCR kits and 1 point-of-care diagnostics. So that's the plan. And hopefully from Monday or Tuesday, we would be going live.
And what are the genes that these kits basically identify? Which gene?
Yeah, so essentially we have a screening test which is concentrating on the E gene, and we are having a confirmatory test which, depending upon the kit, there is the ORF gene or the RNA-dependent RNA polymerase gene. So that's the plan. So E gene for screening and ORF or RNA-dependent RNA polymerase for confirmation.
Okay, and I'm glad that you're thinking about locally made reagents, because reliance on any other country is a disaster this time, because there are no transport links and cargo links. So it has to be indigenous. That's what you want. Yeah.
Actually, looking at 2 or 3 different manufacturers of real-time PCR kits, one of them is indigenous and the other ones are from abroad. So we are hopeful that, but we are going by the results published in the ICMR website after the NIV evaluations. So yeah, so that's where we are.
What I'm saying is they may not supply reagents. People abroad may not supply reagents, and that's been a problem.
Yeah, that's a problem because there is a global demand of kits. And it's important to have the indigenous kits. So till now, there is a problem with the supply chains, but we are working. That's why our strategy is to work with multiple vendors, multiple manufacturers of kits, and multiple systems, so that the system does not get stuck up with one kit or one system.
Yeah, good. And what are the kind of numbers you're talking about when you start? And what do you think? How quickly can you escalate? How many?
Well, we are yet to have an idea about the actual numbers. I will tell you that the scenario in India is that probably in the last 5 years, there has been quite a change in the molecular diagnostics arena, especially molecular diagnostics in respiratory virology.
Mm.
And so there was a time when we introduced the real-time PCRs for respiratory viral infections.
Mm.
We were testing very few samples. Now, uh, and part of it was because of lack of awareness about the existence of such facilities, lack of awareness about the utility, clinical utility of these tests, and finally lack of awareness, and actually also the affordability question, because in India still there is a significant proportion of patients who actually do out of pocket expenditure with regard to healthcare. So it's not like the NHS where you have
Everything
the
free.
so so the cost has been a determinant, but I think increasingly clinical colleagues are realizing that it is good value for money to have a syndromic panel tested, because that saves on a lot of things. That saves on antibiotic cost, and by inference also on generation of antibiotic resistance from increased antibiotic use. And also it helps to make a specific diagnosis, and people can decide whether the patient actually needs an admission or can be managed or should be given a specific antiviral treatment.
Okay,
So
okay, good.
the numbers, so we test anywhere between 5 to 15 samples a day for various respiratory viruses. The number of targets tested depends upon the amount of money people are actually able to pay. So we have tests only for influenza viruses A and B, H3N1 and H1N1, H3N2. But we have also got extended panel, which includes about at least 10 viruses and two
Mm.
atypical pathogens. And with the extended cartridge-based amplification test, we may be able to provide up to 22 pathogens, including the COVID.
Okay. So our experience on that is completely different because the obviously the outbreak is at a more advanced stage here. Um, so we started off with one gene. This is the Collindale assay on specifically on the RDRP gene, in-house assays. The people who went with the big companies like Roche or Hologic or say any of the bigger companies, they were hit very hard because the US decided to start testing everybody under the sun. So all the reagents were exported from Europe to US. So all these people who relied on, say, Roche or Hologic, they're all suffering. The It's the same with some of the commercial kits, except Aus Diagnostics, who still has stocks, be it Altona or any of the other companies. There are issues of supply chain. Yeah, and now the strangest, weirdest thing now is there's a complete lack of swabs in the UK. So we are have to, looking at dry swabs and the swabs in saline, swabs in lysis buffer. So all sorts of things we are looking at. So we started the Collindale. The assay was ready in January. They distributed it to the big public health England labs like your Birmingham, Bristol, Cambridge, Southampton, Manchester, Leeds, and Newcastle. And 3 weeks later, end of February, they distributed it to 4 or 5 NHS labs like ours in Kings and guys in St Thomas and a couple of others in Sheffield. Within and the algorithm included the RDRP gene, and if it is positive, every positive sample had to go to Collindale for confirmation and sequencing. So that would take 24 to 48 hours delay. Very quickly, it became apparent that's not a practical solution. 2 steps. It has to be one test, and that's it. So in the beginning, when we were all swimming to find out, just to see what's happening, the 2 step works. But once the numbers escalate, that will not work. So you have to make a local decision as to have just one gene. So that's one. And the same with the syndromic panel. In the beginning, we used to use all this, for example, ICU patients coming in. We would do the coronavirus testing and actual primers and probe designs and everything. And that is in the beginning. But that's since been superseded by lots of commercial assays. And what the Colonel do is with the evaluate kits. So Collindale distributed the positive controls and initially asked us where to get the reagents, and then they were insured. But now those things have been overtaken by commercial companies. They distribute their own thing. And again, if it's local, then we tend to get the supply on time reagents. But if it's international, we have a problem. Respiratory panel. In the beginning, again, we used to do the respiratory panel along with coronavirus, and the sheer number of infection is such that we stopped doing that. We so the number one is coronavirus testing. Number two, in ICU, where its coronavirus is negative, only then we go on to do the respiratory panel. So,
Okay.
and also that's because the enzymes used in the respiratory panel, we have to make sure there are enough stocks for it. You
Okay.
don't want to exhaust your stocks. So I wouldn't recommend doing it in parallel, especially for everyone coming in straight away, because when it hits you, just to give you a feel, about 40 to 50% of our samples are positive. And we get
50%. That's a large number.
yes, and so our capacity when it started in a lab, we started on 29th of February, where 8 samples a day. Quickly, it moved on to 40 samples a day next day, and then we within a week we were on 120, and within 2 weeks our capacity was 320. Now, last week the capacity was 500. Now our capacity is 1,000. So we are getting
Wonderful.
600. So we're getting 600, 700 samples a day, of which 40% are positive, 40 to 50%.
Right. Right.
So whatever you do, every other diagnostic thing do in your lab you need to stop doing that and focus on this when it hits Calcutta. You're very good at automation and things. Unless you automate things, you cannot use manual things or anything that's manual. It has to be automated completely, including the way the IT is there. Because as virologists, we have to focus to make sure the laboratory runs well. Leave it to the administrators to deal with the results. Leave it to the logistic people to bring the samples in. Leave it for everyone else to do infection control. There are people who can not do your job. Nobody can do your job. That's my experience. Nobody can do my job, whereas I can do their job. So I should focus on my job, like the infection control, the microbiologists, they can do the infection control aspects. The infection control nurses can do that. The pharmacists can deal with the trials and things, advise on those things. The hospital administrators can think about closing a ward, opening a ward, and everything. We can go and do their job for them, but none of them can do what we do, which is escalate the number of tests that we can do in the lab and make sure it's
Right.
robust. So that's how I've been. So that's the one thing I'm doing. And the second thing I'm doing is last weekend I've been nominated as UK clinical lead for mass testing. We started out as the lab started working on Wednesday last construction. Construction finished this Wednesday. We started at our last Thursday was like 40 samples, then quickly to 100, 200, and beginning of this week was 500 and 1,000. Now already we are on 1,000. Next week 3,000, 5,000. So by the end of April, we will be testing 100,000 samples a day just in one center in Milton Keynes, and we'll go on to do 100 more thousand in Manchester and in Glasgow and in Belfast. Now, the reason I'm saying is unless we escalate it to that numbers, there is no way any country can control the virus. You name it, be it China, South Korea, Taiwan, Japan, Singapore, Hong Kong, Iceland, Norway, even Germany. The reason why the mortality is low in these countries is they are looking at everything that's happening in the community. Everybody is getting a test, and the moment they know that someone is positive, if not that generation, the following generation of contacts, you can control them, and that's how the virus is not spreading in the country. And because they're picking up so many more cases early on, they know exactly where to direct the resources. So we are looking at a completely different way of thinking in within virology, and the unsuccessful countries are the ones who ignored it. Classically US, where US looking at the number of mortality. Now of course they cranked up the testing, so that effect of the cranked up testing you will see only in about 3 to 4 weeks time along with the lockdown. Until then the mortality will go on, it will keep on increasing. we can't control, as virologists, we cannot control the political social lockdown. We cannot control the reagent supply. We cannot control the infection control aspects too much. We can provide guidelines and everything. But what I feel philosophically we can control is the volume of testing we can provide in a worldwide emergency. And that's what I'm looking at in a big way, be it testing the patients or testing the staff members. So one of the other unusual problems we had was because the number of tests offered in new labs within UK were so low, they could not afford to train healthcare workers. So we had the capacity. We tested our healthcare workers. Our healthcare workers are back. In many of the other hospitals, you see the notice, because they don't have the capacity to test, they are unable to bring the healthcare workers back to work. So if you don't bring the healthcare workers back to work, you're looking at more patient harm because the wards are not staffed, the ICU teams are not staffed. So you have knock-on effect where it becomes unsafe.
Yep.
So that's where we need to break that cycle within the hospital. We need to break the cycle within the community, and the only way you will sort this is you need to think big, absolutely big. Yeah, the Germans have cracked it. Their Germans are testing, yeah, 250 or something thousand a day, 500,000 at least in a week, just on the PCRs. So we will reach that end of April, bit late, but we will reach there. The Koreans have cracked it, yes, but then they're using a variety of antigen assays. I don't know how good the antigen assays are. You know about my mantra on antigen, you need to have neutralization. So we don't know how specific they are, how sensitive they are. And IgM and IgG at this time, there is no role for it in the middle of an epidemic at all. It's after everything is finished, then yeah, maybe there's the role. Again, UK has evaluated about 15 different systems of ELISAs, 10 to 15, and none of them have proven to be very, very good. The best is Euroimmune and Fortress. Nothing, there are lots of Chinese and Korean assays. We don't know how they are. We don't know how they perform. The Koreans and the Chinese, what they did was they had multiple things. They had the antigen, they had the antibody, they had the PCR, everything, mixture of everything on everyone. So that kind of thing we cannot afford. Chinese, for example, they built that lab in 5 days flat to have 10,000 PCRs a day. At that time, we thought, oh wow, but that's because it was just one city, Wuhan, and they supplement, and there are thousands of people who died who went undiagnosed. So you have the peculiar problem of all the post-mortem diagnosis we need to come to when the numbers increase, because nobody would have tested, and all these people have lonely funerals where absolutely no one can attend. So you're looking at a totally post-apocalyptic scenario where our priorities as virologists also are different. Our priorities in the community socially also is totally different. There you go. In that gloomy note. Sorry.
I have a question for you, Sudanwa.
Sure.
Yeah, it's very interesting to know that what you are currently doing and achieving in terms of service and numbers. So my question is, how are you managing such massive numbers? But is it distributed among various labs, or when you are talking about, I understand up to 1,000 samples, but I'm unable to understand 100,000. That's beyond my.
There are three pathways. Labs like ours and Birmingham. We are capacity is 1,000. In 2 weeks' time, we can go to capacity of 2,000, and maybe in 3-4 weeks' time, we can do 4,000. All because of complete automation on the TCAN machines and the Kingfishers and the Quant Studio, and the reading of the PCR readings via the artificial intelligence, which have written all the rules and all. And we are hoping to multiplex this. At the moment, it's singleplex because it's a colonial assay, singleplex RDRP and singleplex MS2. So in a play test, if divided into two halves, it's a bit silly. But anyway, that will change. Once that changes, we can increase the numbers to 4,000. That's also because we start work at 6-7 in the morning and finish at 7 and midnight. Like people are there in different shifts. The machine idle time is confined. That's the NHS existing lab scenario. Then a lot of district general hospitals are getting onto the bandwagon, and they're trying to do things. But again, they don't have a necessary number of scientists to do in-house assay. They could look at the Roche assay, for example, but the Roche assay, if they have, the, for example, HIV RNA, same 6-800, you can put it on those things. That's suitable for district general hospital, but they're not coming along in a big way. Then the second strand is the research in UK on every research lab in the UK have been told to not to do any research, and they all have PC extraction and PCR machines, and they've been told stop doing your cancer genomics or this or that or whatever research. Focus completely on coronavirus testing. So the Crick Institute, for example, in King's Cross, they started testing on behalf of Northwest London. So same, the King's College London, in collaboration with King's College Hospital and Viapath, the pathology that manages the pathology equipment and people in our lab, they are all coming together to form another lab as a resilience lab with an intended capacity of 4,000 to 5,000 a day. So this is the second strand where the universities are coming together. They all know it is temporary for maybe 3 to 6 months. They all know when the lockdown comes down, they go back to their normal lives. The primary techniques and ability to do the testing, they don't want to sit around twiddle thumbs. So they are becoming very, very active. Then the third lab strand is the super lab in Milton Keynes, Manchester, and Glasgow. What the army has done is, then, for example, they know from the maintenance manuals where all the Thermo Fisher ABI 7500s are. So they've gone with the army trucks and grabbed it from every research lab in the country. So in Milton Keynes, there are 90 Thermo Fisher ABIs 7500 machines. 90.
My God.
Yeah. And this weekend and then tomorrow, we're going to recruit a lot of people, all the scientists again who are volunteers. They'll all be paid. Yeah. So they're all will be trained up. And that's how we manage to achieve these kind of numbers.
Right.
So 3 different strands just for PCR.
Okay. I'm going to just take another, ask you another question. I'm just diverting a bit and going into the question of infections. And there are 2 types of which seems to bother a lot among people in India and possibly many other countries and communities across the world. One is the question of infection in healthcare workers. So how common or uncommon is that, especially if you are wearing your PPE properly? And second question is, what about infection among lab workers who are handling the samples? I know there is a lot of automation which is going on in your lab both in terms of sample handling and extraction, etc. So
the second one is easy to answer in our laboratory because we've handled influenza and everything else. Straightforward, the infection is 0. Yeah. I mean, okay. We have the class 1 cabinet, and then that's where the swabs are done. And if it's a BAL or endotracheal aspirate or sputum, then it goes to the CL3 lab proper where it's processed. So it's infection in the lab is 0. So people shouldn't be worried about it. So people who are researchers who are suddenly coming into the diagnostic field, they're worried about it. Yes, it's 0. Healthcare worker is a bit more complex. If you look at the data from the WHO COVID mission to China, where about 2,000 and odd healthcare workers of the 55,000 that was in that particular report, 2,000 on odd, 2,045 or something, healthcare workers actually fell ill. And being the Chinese being very, very aggressive on the infection track and trace, they sent 4 to 5 people to question the family of the healthcare workers and, of course, everyone else. When they did that, they found of these 2,000, 80% of them had acquired it because of a family contact or a social contact. 80% of them, because they were from Wuhan, they're working in the same hospital, they acquired it. It's only the remaining 20% could have acquired in the hospital. Yeah, I'm sure they acquired in the hospital. Yeah, in the remaining 20%. So that is the problem. Like same thing, we've had ICU consultants and pediatricians and ENT surgeons and neurosurgeons acquiring it because they are working close to the anyone working close to the face area, be it ICU consultants on intubation, be it the ENT consultants, they are the ones who are affected.